Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in this very interesting case. Now, I'm going to explain this case history to begin with, and also this is not actually the beginning of the procedure. I'll explain why I'm showing you from here. So, this patient has had 2 previously failed attempts of having the earwax removed, and I don't blame that specialist at all because it was really tricky. So I initially used the endoscope, but then I reverted to the wax scope, and the reason for that is that this patient's ear canal, it was so hairy at the entrance and also extremely narrow that when I was stretching the ear open using the endoscope, I couldn't see anything. All I could see was the hairs. Now, so then I went to the wax scope. Now, I've actually added the clip from the wax scope at the end of this video. So you will see the benefit of the wax scope actually, because I was able to actually get a better view of this wax with the wax scope because the specular was stretching the ear canal wide open. And but then I decided to revert back to the endoscope, and I don't often ask or get patients, friends or family who attend to do this, but the patient attended with their daughter, and I actually got the daughter to stretch this patient's ear open so I could go back to the endoscope because it's a really complex case. So I just felt that I'm going to go back to the endoscope to try and remove this. So this ear is actually stretched open by the patient's daughter. And with that, in that way, I don't have to use the endoscope to stretch the ear open, meaning that the endoscope tip is not up against all these hairs. And also, the ear was so narrow that I've had to use the endoscope to stretch it open anyway, and it was right up against this wax. It's really interesting because as I edited this video, before doing this narration, I just got an email, and it's from a specialist, and you're going to see the email in a moment. It literally just came into my inbox. It's from a ear care specialist working for the NHS, and they've just asked us some advice about hairy ear canals, and they're trying to look for some videos on my YouTube channel. So that's the email. So I'm going to discuss how best it is to try and navigate these hairs. And you can see this patient's got loads of hairs. They're right here, so do stay tuned, it's even worse. So the outer third of the ear canal, the cartilaginous portion, is where you'll find these hairs. You won't find these hairs in the inner 2/3 part of the ear canal, the bony part of the ear canal. So the outer third of the ear canal, the skin that lines it, it's 1 millimeter approximately in thickness, and you've got 3 layers. You've got the epidermis layer, and then you've got the dermis layer, and it's in the dermis layer where you find the hair follicles. And underneath the dermis layer, you've got the hypodermis layer or the subcutaneous layer. So that's essentially a layer of fatty tissue. In the inner 2/3 of the ear canal, the bony part of the ear canal, you don't have the dermis layer of skin. You've only got the epidermis. That's why you shouldn't find hair. So if you find hairs very deep in the ear, they've either been pushed in or they've been trimmed and they've flown into the ear. So in the case of the right side, you will see loads of hairs really deep in the ear. So I suspect this patient had either been trimming their ear hairs or been poking in the ear. Hairs are more typically found in male patients. Although this is a female patient here, so you can see they've got loads of hairs, and I'm just using the right hook there to extract it. So I'm using a combination of forceps and the right hook. But generally speaking, males tend to have more hairs, and elderly, as patients get older, they generally have more hairs. And that's because these hairs are actually almost desensitized to testosterone up until a certain age as we get older. And something triggers when we get older, whereby for men, because we've got more testosterone, these hairs then become sensitive to testosterone, and they become thicker and they grow longer. And I think Asian patients, anecdotally anyway, I know I've got hairy ears as well. Generally, Asian patients have more hairs, so there must be some genetics there as well. and it can make procedures difficult. Now, for deeper wax, with an endoscope, it's probably the best way of navigating these hairs, because all you have to do is insert the endoscope past those hairs and then you can see everything. But when you use the wax scope or an ENT microscope or head-worn microscopes, which is what most people really use, not everyone uses an endoscope, the hairs can become a problem because the lens is outside of the ear. So it's almost like a telescope. I'm just trying to break it down so it's easy to kind of almost visualize, but you're looking, the magnifying lens is outside of the ear, it's external. With an endoscope, the magnifying lens is actually inside the ear. So if you just position that magnifying lens past the hairs, it's not a problem, but it's a problem when the hairs are more near the entrance, I would say, with an endoscope, because when you're stretching the ear, and if you've got extremely hairy ear at the entrance, it's going to obscure the view because they're going to be right in front of the endoscope. Now, normally, the hairs don't really cause me much of an issue. I can navigate that. But in the left side, it was really, really tricky there, I must admit. So what can be done? Now, I've tried trimming these hairs using curved, rounded-nosed kind of scissors, which are designed for nasal and ear hairs. I find it really, really tricky, especially in narrow ears. You just can't get that precision. And I found it, unless the hairs are more external, like they're hanging out and they're visible outside the ear, it's really, really tricky. I also purchased an electronic trimmer and it just didn't work for these hairs. They work, again, quite well for the external hairs, but they're not the ones that are really causing problems. It's the ones that are past the first bend, so they're kind of more inside the ear. They're the tricky ones. Now, you can't wax these because the ear canal is so narrow. You really can't. It's very difficult to see when you're doing stuff like that. So what are the solutions? So they're not going to work. I've tried the scissors. I've tried the electronic trimmer. Patients actually found the electronic trimmer really, really hot as well, but it just didn't cut the hairs in the way I wanted it to. So what can be done? So if you're using an endoscope, you can use forceps to pluck some of these. Now, I've done that before. It's relatively well tolerated by patients. You just pre-warn them it's going to feel like a pinch, and they're generally okay. But that can be quite tedious. But with an endoscope, that's probably the only other solution. And again, it's not a common thing. I mean, this is the first time I felt like, I needed to get the patient, family member to stretch the ear so I can have the lens outside. So they're not up against the hairs, so to speak. But now, if you're using a speculum, so with the wax scope, there's a speculum. Now, one way of mitigating it is when you put the speculum into the ear, you kind of rotate it. And when you rotate it, so you're almost twisting it, these hairs that are a bit deeper, they get caught in between the canal wall and the speculum, and because you're twisting it, you're curling them, you're bending them away from the opening of the speculum, if that makes sense. Sometimes if you just push the speculum in, and the really, really long hairs, you're just pushing the hairs closer towards the eardrum. These are hairs that are attached, by the way, they're not loose hairs. I'm talking about the ones that are protruding from the ear. So you're kind of gliding the speculum into the ear, you're almost pushing the hairs forward towards the eardrum, and then they can overhang at the end of the speculum. And then it obscures the tip. So when you twist it, you're moving the hairs more sideways as opposed to forward. So that's one tip. Another tip is to use a smaller size specula than what you probably would normally use with a patient. So we have different size specula. So if you use a smaller one, the reason for that is you can probably get in a bit deeper. Now, most speculum, you can't over-insert them. These are the ones that are designed for earwax removal. They are tapered, so it prevents over-insertion, because we don't really want the speculum entering the inner two-thirds of the ear canal, the bony part, because that can be uncomfortable for the patient. So they're kind of like a stop mechanism to prevent you from over-inserting. But with a smaller speculum, you can probably just get in a millimetre further, or maybe two, and sometimes that can make a big, big difference. Another solution is to use a Gruber type speculum. Now, a Gruber type speculum, again, it does go in the ear a bit deeper. Now, most specula, they're circular, but the Gruber specula, it's more oval shaped because our ears are more oval. So it can allow a bit more additional depth because you're not pushing against the side of the canal wall. So if you're using a circular speculum, which is the norm, I use that for the wax scope because of the optics, we have to use that. And because we've got a slot at the top of the specular, we need to have a circular specular to accommodate for that. But if you're using a microscope or head-worn loops, if you use a Gruber specular, you'll have less resistance against the back and front part of the ear canal. With a Shea or Shea, what's the other specular called? It's just left me, but it will come back to me. But if you use a Shea, which is a typical type of specular, because it's circular, you might get resistance against the front and back part of the ear canal, but as I said, the Gruber one, it's more oval. But the issue with the Gruber specular, the oval one, is that you can't twist. With the round specular, you can twist, but with the Gruber, you can't. It has to be inserted in a certain way to enter the ear, so you can't manipulate it in that way. So it's got its pros and cons. So I hope that helps. So that you can pluck them using forceps. When you insert the specular in, twist it. That's only for the round specular. Use a smaller specular than you normally would for that patient. Because it might allow you to go a bit deeper to push those hairs, the deeper hairs. So we're talking about the hairs that are on the boundary of the cartilage and the bony part of the ear canal. They're the ones that are problematic. The ones on the side near between the first, just past the first bend, the specular will do the job for that. A normal specular. So yeah, a bit of a smaller specular to go a bit deeper. Or use the Gruber one, so you can get a bit deeper again and trying to push those hairs that are a bit deeper in the ear canal away. Now, I've totally kind of ignored and not described what I'm doing with this right ear. Now, I actually made this patient's right ear worse. So it was really tricky. There was loads of hairs and I managed to remove the majority of those hairs. And it was just this last bit. But it was so difficult to get access into this patient's ear. It's just so narrow and bending. Obviously, it doesn't come across on the video. And when I could get in with the endoscope, that wasn't a problem. But with my instruments, I wanted to position them in certain angles to remove this. And I just physically found it difficult getting the right angle. Then I used the forceps. And I think with the forceps, because there's nothing really to grab onto, you've got these little few hairs, but you're not going to grab onto those hairs and pull this out. And so what happened, the tip of the forceps actually pushed this further in. And that's why sometimes when when I read some of the comments about why didn't you use the forceps, well, this is one of the reasons, because you can actually, you've got nothing to grab onto, you can push it further in. So I actually did make this worse. Although I was happy with moving all what I did, and at that stage, the eardrum was mostly visible, if truth be told. They could hear really, really well, but I tried to get this last bit out. So this was a real challenge. Now, how did I get this out in the end? I'm trying to just recollect. So because of, and again, it doesn't come across in the video, but it's really difficult getting the right angle with the instruments. So fortunately, I've got all different types of suction probes. They have different angles, different bends. Their bends start at different points on the suction probe. And there was one where, so normally the suction probe that we use, the tip end is 3.5 centimeters. Then you have a bend, which is 30 degrees. And then you have like another, say, 5 centimeters length of tube. So the one I use is a bit different. The tip of the suction tube, there was a longer tip, so that was about 6 centimeters. And then you had a 35-degree bend. And then after that 35-degree bend, there was an additional 3 centimeters. And it just gave me that leverage. That's what I'm using at the moment. But the diameter of that particular suction tube was a bit smaller, so it was slightly less powerful. So I used it to bring this forwards, but it's trapped now in the isthmus. So I've now gone back to the other suction probe, the one that we normally use, the standard Zollner one. Because now that I've managed to bring this forwards, I didn't have that same issue with the angulation. And this one's slightly more power, very minimal, but I just felt to go back to that, and I'm just so careful not to push it back. You're going to see once I remove this, they've got a really widened middle part of the, really widened deep part of the ear canal. That's why it got lodged there. So I brought it forwards. And I also think when you put the drops in, actually made that worse as well, because I think the drops, when I got the patient to tilt the head across, the drops penetrates. When I took the drops, when I asked the patient to tilt the head to drain the drops, when I look back into the ear, the wax, the matted wax, this is very heavily matted wax. It looked like it went deeper, so almost glided the wrong way. So, but we got there in the end. And it was quite frustrating after I used the drops, because every time I went in with the endoscope, the hairs just, as I was inserting the endoscope, past the hairs, so the hairs actually technically wasn't obstructing my view. As you can see, I'm just going to go past those hairs, so they're no longer an issue. But it smeared the lens, and I dried the hairs. I put a bit of cotton wool just at the entrance to absorb all the drops off those hairs. And eventually I managed to dry them enough, but every time I went in, I had to come back out and wipe the lens. And the patient was obviously thinking, what's he doing? So I had to obviously explain, look, this is what's going on, this is the issue. And I showed them on the screen as well what the issue was, because I don't want to continue if I can't really see so well. So I managed to remove that. And you're going to see, there's a bit of wax there. You can see there, it just blurred the lens there as well. So I'll just come out, that's a good example. So I'm just trying to insert the endoscope through those hairs where there's an opening so it doesn't smear as much. Managed to get that piece out. If you look at the deeper part of the ear canal, it widens both on the right hand side and at the bottom. That's the anterior recess to the right, and at the bottom, inferior recess. But yeah, really, really pleased with that. Now, this is the patient's left ear, so right at the beginning of the procedure. And you can see I'm using the specular to stretch open the ear. And although there's a few hairs there, I could still see what I was doing. So it wasn't much of an issue. So the hairs were getting pushed out of the way. And I had a much, much better visual initially with the wax scope. But it was just trapped. So this is why we developed the wax scope in essence. So when patients when specialists struggle to widen the ear canal, the speculum can help. Now, obviously, I went back to the endoscope, but it was just because I knew it was going to be a really complex procedure, because this patient has had 2 previously failed attempts. And for me, obviously, I still believe the endoscope is the best method of earwax removal. So I just went back to that. I just felt a bit more comfortable with that for this more complex procedure. So you can see again, those hairs now, they're not massively causing me too much of an issue here, but when I first used it with the endoscope, all I could see was hairs. It was all reflective. I couldn't really see anything. So I'm stretching the ear, and when I put the instrument through, it's pushing some of these hairs out of the way as well. I'm just giving it a wriggle. So essentially what the speculum was doing for me was what the patient's family member was doing, pulling open the ear. And otherwise it was completely shut, the entrance of the ear canal. Now, I don't often get patients do that. I think probably once or twice a year. Partly because you can get the patient to do it themselves, but they have to use their opposite hand and they have to go behind their ear and pull their ear back. And that can be quite tricky for some patients to do. Also, when patients do that, they generally move their head into a kind of an awkward position for me. You can always get them to you can reposition their head afterwards, but it can be quite, obviously if patients are elderly, they've got mobility shoulder problems, it can be difficult, and it can be quite tiring for them, or you can obviously give them a break. I'm just using the ear pick here actually to bring it forwards. Now, I'm pretty sure I would have managed to get this out using the wax scope, but as I said, just preferred going back to the endoscope. So I've just re-angled the speculum so I can put the forceps in. And beginning of the videos, you'll see I was continuing to use the forceps. So immediately after I swapped from the wax scope, used the endoscope and was continuing with the forceps. And yeah, sometimes patients, if they can't do it themselves, they may not have anyone attending with them. I don't have an assistant to help. In the past, I've asked Tracy or Darmister to kind of assist as well if I really, really had to. But when we do our clear wax training, I do teach our delegates that, because at first they will really, really struggle. It's just one of the things with an endoscope. So it's their kind of get out clause. If they really, really struggle to stretch the ear, then we show them how to get the patient to stretch the ear open themselves. So I'm using the correct. So I know the view, for me, this view was actually amazing. It just felt, I was stretching the ear open. But at that stage, I went back to the endoscope. Now, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.